Good afternoon, everyone. Welcome back. May I encourage you to just come forward a little bit, because that is if you're sitting towards the rear of the Celtic Hall. I think for this session in particular, if I could encourage you to move up a few rows, that would be really helpful. And welcome to those joining us online. Thank you for being with us today. My name's Scott Drummond. I'm the Program Manager at VADA, and it is my pleasure to chair this session on the Joint Addiction and Mental Health ECHO, a demonstration of mental health and AOD working together. And in the context of the conversations we've been having this morning about integration and working together and working across sectors, this I think is a really excellent example of mental health and AOD clinicians and other clinicians coming together, supporting each other and also supporting clients and consumers. I'll introduce Professor Ed Ogden, and then I'll ask Ed to introduce his colleagues. Professor Ed Ogden is the Deputy Director, Addiction and Forensic Medicine at the Centre for Human Psychopharmacology, Swinburne University, a staff specialist in addiction medicine at St Vincent's Hospital in Melbourne, and the addiction medicine specialist at Goulburn Valley Health. He's a Fellow of the Royal Australian College of General Practitioners, a Fellow of the Chapter of Addiction Medicine of the Royal Australian College of Physicians, and a Fellow of the Faculty of Clinical Forensic Medicine at the Royal College of Pathologists of Australia. His research interests focus on the role of AOD in traffic safety and the development of treatments for AOD and drug abuse. He is working with academic and clinical colleagues to form a Centre for ADHD research with particular interest in ADHD and substance use disorder. Please welcome Ed, and I'll ask you, Ed, to introduce your colleagues.
Thanks, Scott. The reason for my having my colleagues with me will become more obvious, but I introduce Cheryl Sobchak, who happens for her sins to be my boss, and Sharon Hall, who's a nurse working in our addiction unit. So what I'm going to do this afternoon is tell you a little bit about Project ECHO. Scott asked me to talk about Project ECHO, and I thought that'd be really boring if it was just me standing up here talking. So we thought we'd demonstrate an ECHO session for you. Normally I would simply chair it and I'd have somebody else doing the presentation. So Project ECHO, which has, in fact comes from Extension for Community Health Outcomes, was the brainchild of Sanjeev Arora. In 2003, Sanjeev, who is a gastroenterologist, had a 43-year-old single mother come into his clinic with a distended tummy in liver failure, and in fact diagnosed with late-stage liver cancer, and she died within 6 months. He said to her, "Why have you taken so long to come for treatment?" And she said, "Because it's too far." She lived 5 hours drive away from Albuquerque and was unable to access treatment closer to home. And so Sanjeev started this idea of a community of practice. Everybody in New Mexico had the protocols for treating Hep C, but many people didn't feel they had the courage to do it. And so he started Project ECHO, and rather than me talk too much,
every day around the world,
here's the man himself.
People suffer and die from diseases we know how to treat and cure. We created ECHO to solve this problem. I'm a liver disease specialist, and in 2003, there were very few doctors in New Mexico treating hepatitis C. Patients waited 8 months and traveled hundreds of miles to see me, and I was only able to treat a tiny portion of patients who needed care. People were dying, and I knew, had they been treated earlier, lives would have been saved. The challenge was to treat all New Mexicans, even in the most remote and underserved areas. That's how ECHO was born. We created a knowledge-sharing network which used video conferencing to mentor and support doctors and nurses across the state. Over time, they became great experts. Patients received care in their communities by their doctors, and the wait in my clinic fell from 8 months to 2 weeks. At its core, ECHO empowers people with the knowledge and support they need to reduce human suffering. With our global network of partners, we have replicated the model for 40 other disease areas in 16 countries. Our goal is to touch the lives of 1 billion people. With your support, we can ensure that the world's most vulnerable benefit from the world's best collective knowledge.
So the concept of Project ECHO was, rather than making people travel large distances to get specialist help, specialists could reach out and support people in their local areas to upskill and look after people closer to home. So since that video of Sanjeev was shot when he was talking about it being in 16 countries, Project ECHO is now in 93 countries, 93%, sorry, of countries. There are 600 plus training centres and 3,000 or more ECHO programs, of which I'm very proud to say that the ECHO program that we run out of Shepparton is one of 2 in the world, which is a joint mental health addiction program. The other one's in Canada, in case you're interested. So ECHO is not traditional telemedicine. It is not someone with expertise conducting a one-on-one consultation with a patient. It's an opportunity for us to all share our knowledge. One of the things that I get very excited about in our ECHO sessions in Shepparton is the breadth of people who get involved. We've got people who will present cases who have a Cert 3 in AOD. One of the frequent visitors to our ECHO clinic is Sarah Romans, who's Professor Emerita of Psychiatry at Wellington, New Zealand. If we've got a program that can reach from people with minimal qualifications to people with amazing qualifications in a safe space, we've created something really special. And the motto of ECHO is all teach, all learn. It's not like those of us in the centre think we know anything. I've never been in primary practice in the country. I've never been a nurse, for which the community is undoubtedly grateful. I know what I know, but I don't know what you know, and this is an opportunity for us to share. And one of the reasons that makes it so important is that what could be known is so much more than any of us can hold. If you go back a couple of 100 years, the most intelligent people could know everything that was known. Benjamin Franklin wrote about the art of war. He wrote about how to build a better fireplace. He was considered an expert on economics. He knew a lot about physics and chemistry because you could know everything. That's no longer possible. None of us can know everything. And so the idea of the ECHO model is that we use technology to amplify what each of us knows and to share it, so that as a community of practice we all improve. So this is Sanjeev running an actual ECHO. This is what it looks like with a group of people around the table who form the hub. It's a group of people who can add their expertise from the centre as required. Can't replicate that for you, but this is my mini hub. So ECHOs only work if everybody gets involved. This is your opportunity this afternoon to have a go and get a bit involved. Sharon's going to present a case, and we've got an opportunity to talk about the case. So what normally happens in an ECHO is this. Normally someone gives a brief didactic. Today, it's me. And then after the didactic, we would normally stop and have a chance to ask questions about what's been presented. And I'm happy to do that. But most importantly, after the didactic and we've had some information from someone, we discuss one or more cases. So on this occasion, Sharon's going to present the case. And what I like people to do when they present a case is to actually ask a question so that the community of practice can add their suggestions about what might work. So the way it works, the case is presented with the question for the community of practice. Then there's an opportunity for everybody to make sure they understand. So there are questions of clarification. At that point, we don't want suggestions about management. We want to make sure that you understand the patient that's been presented. And then we have an opportunity to use our collective knowledge to assist whoever's presented the case with recommendations about how they might go forward. And then, ideally, those recommendations are recorded and the treatment plan can be sent back to whoever presented the case. So hopefully that gives you a bit of an idea of how an ECHO should run. There are 2 ECHO programs in Victoria which you may be interested in. Obviously, we'd be very happy to see you at the JAMH ECHO, the Joint Addiction Mental Health ECHO, which runs at lunchtime on Thursdays. And if you're particularly interested in opioid dependence, then St Vincent's run the opioid management ECHO, which happens at 7:30 on Wednesday morning. There are other ECHOs in Victoria. There's an early childhood development ECHO. We've just started supporting Spectrum with a personality disorders ECHO. There are moves afoot to start ECHOs in other specialist areas. Out of interest, I'll mention that in the US there are lots of educational ECHOs. It's a beautiful model for teachers to talk about problems in the classroom. One of the ECHOs I observed when I went to Albuquerque for training was run by the peer support group in prisons. Isn't that beautiful? They actually had peer support workers having this model to support each other, running peer support programs in prisons. And they have dramatically dropped the Hep C rate in prisons, which is... So, conscious of the time, but wanting to leave us, but I want enough time for the case presentation. Are there any questions burning to ask about the ECHO itself? Either you're all stunned or I did a brilliant episode. All right. So...
I've got one question online, Ed. Someone's just wondering how you access those echoes that you mentioned.
If you Google them, high tech, yeah.
Magical thing called Google.
Yeah. And you can. I'll let you fix that. All right.
Ed, can I ask a question just while Julia's doing that? In terms of the didactic, can you give some examples of what the didactic would be about? What clinical kind of presentations or ideas?
Oh, wow.
Because I know there's a wide array.
Yeah, in the last year we've done ADHD and drug use. We've just finished doing personality disorders and drug use in conjunction with Spectrum. We've done a range of mental illnesses. Sharon, what have I forgotten? We're just in the middle of doing correction or forensic issues and drug use. So we started that series with Jim Ogloff, who's the head of forensic care. And we did young people. We've done a series on drug use in pregnancy. We've got the forensic series running now. After that, as far as I can remember, we're doing unusual drugs, so, odd things like ayahuasca and DMT and GHB. We're not constrained. I mean, the nice thing about mental health and drug use is that there's a vast array of subjects. We're just in the process of planning our curriculum through to 2023. And it's spilling over into 2024. So there's no lack of subjects, and we always have gaps in the program so that if somebody says, look, I'd really like to hear about, then we'll go looking for who's best to present on that.
Thanks, Ed.
Sharon, it must be your turn.
Hi everyone, thanks for being here. Today, I would like to present the case of a young lady who is known to the service for which I work. She's a young woman in her 30s. Her background is Australian. She was born in Australia. The question we were wanting to ask is how we can best help this lady to complete a cannabis withdrawal, as well as dealing with her diagnosis of PTSD and other mental health issues. Principally, we're working with her in regard to cannabis use. She's not on any opiate agonist therapy. Last year, she completed a withdrawal from GHB with our service. She began a cannabis withdrawal with us earlier this year, but didn't manage to cease use. We're about to commence another cannabis withdrawal. However, this young lady uses cannabis to deal with anxiety and nightmares. She has used methamphetamines in the past, but ceased this on her own in 2020. Her social and trauma history: she suffered sexual abuse by her older brother from the ages of 2 until she was 10. She currently lives with 3 of her 5 children. Her mother is supportive, but has proved over the years to be not terribly reliable. There are various diagnoses: depression, anxiety, PTSD, and a mood disorder. Medical history: she suffers from poor dental health and has had hypotension in the past. She's been a little prone to fainting. When she's undergone a withdrawal from cannabis in the past, she suffers from nausea, vomiting, and anxiety. She often presents with a heightened mood. There's no evidence or no diagnosis of psychosis at all. Her anxiety increases significantly when she doesn't use cannabis. And she has been found to be quite easily agitated when she feels that she's been wronged, or she feels that she's not being taken seriously, or she's being disrespected. There are currently ongoing investigations into the possibility of this woman having ADHD. Currently, she takes mirtazapine, 30 milligrams Nocte, and uses diazepam for withdrawal. Child protection have been involved with this woman in the past, and the children have been in the care of their maternal grandmother for some time. However, most of them are now back with her. This woman is very strong and very determined, and recently completed a GHB withdrawal. She suffered extreme stress while undergoing this withdrawal when one of her children was abducted by his father, who didn't return the child after an access visit. She has quite a chaotic lifestyle, and as mentioned, very likely has ADHD, and currently is undergoing some assessments for this. She's also now employed and continues to engage with the service. So again, to the question, how can we best help this lady complete a cannabis withdrawal, as well as dealing with PTSD and other mental health issues?
Sharon? So this would be a point where it's over to you. Have you got any questions of clarification? Is there anything that's been presented? Michelle? Scott's going to rush over to you with the microphone so that people can hear you.
How much cannabis does she use? And when you say she's done a cannabis withdrawal earlier, how did she conduct that withdrawal?
She does the withdrawals in the community with assistance from the nursing staff with our service. She uses up to 2 grams per day, but this can increase when she's under stress. And
does she mix her cannabis with tobacco, or does she just use it straight?
Mixes, usually. Sometimes she will use via a bong.
And have you got collateral information about her mental health diagnosis and the reason why she's on mirtazapine, or is that a GP that's just put her on?
Diagnosed by a GP.
Any other questions of clarification? Understand the patient has been presented.
I've got a question in the Zoom audience from Rhiannon. She's wondering, does she want to stop using cannabis, and if so, why?
I'm sorry, I didn't hear the question.
Rhiannon's wondering, does she want to stop using cannabis, and if so, why?
She wants to stop using cannabis. She is of the opinion that it does affect her mental health, it affects her parenting, and she wants to stop using.
May I ask a question? Thanks, Sharon. I'm struck by the question that she would like to deal with her PTSD and other mental health issues. I wonder where the brother is at the moment in her relationship, considering the sexual abuse by the older brother from a very young age. Is he still in the picture?
No, he's not.
And has there been any criminal charges at all in relation to that you're aware of?
I'm unaware of any.
Okay, are there any further questions of clarification?
I've got two more.
Yeah, come for a sprint.
We'll go to one from you, Julia,
One
first.
for me. So I've got, has there been any AOD counselling following her detox?
I'm sorry, was that about counselling?
Has there been any alcohol and drug counselling following her detox?
Yes, she remains engaged with our service for counselling and for care and recovery.
Hi, I have a question more around clarity. So through the referral process, and the question for me, so in saying Australian, like the Australian and then Australian, I think it's important, and this is probably just to say that, did she identify as Aboriginal, Torres Strait Islander, or both? Would be great to add to the form, because then there's all these other opportunities that will come up. So, if she identifies as being Aboriginal, then there's these other Aboriginal supports that have been in place, or looks like that question's going to be answered. I feel like you've got to say yes, they changed.
It's normally there. I don't know where it went.
Because I think that's really important, just so, because there's no opportunity for me to say, well, I want to tick the Aboriginal box, or both.
And given that we're based in Shepparton and we've got a pretty good relationship with Rumballara there, I don't know why that's missing.
But I hope she's all right now.
Somebody's got to keep us on our toes. Are there any other questions of...
Yes, we do. Julia,
Alice,
we'll go to you.
Who's wondering who are her supports, and are there other services involved in her care?
At present, there's no other agencies involved in her care. She is supported by her mother, and she is actually receiving a lot of support, although informal, from her place of employment. She's doing very well with that, and that's actually giving her a lot of confidence, and she's well supported by our service.
Thank you. There's quite a few more questions, and I am aware of time. Maybe I'll try and pick through one or two.
Yeah, I just wondered, it may not be relevant in terms of her cannabis withdrawal, but the depression, anxiety, PTSD and mood disorder raise red flags for me for borderline personality disorder. Is that a potential diagnosis that has been missed, or is it looked at?
There has been some assessments done by our psych registrar at our service, and I think that there was consideration of it. However, I think that the diagnosis that they went with was PTSD. There's some other aspects of a BPD diagnosis that aren't there, that we would have expected to see.
Julia, you know one?
A few others, sorry, I'm just trying to fish through. Someone's wondering, where is she at with her ADHD diagnosis?
One of the other clinicians is actually still working on that with our psychiatric registrar.
Behind you, Scott.
Thank you. Beg your pardon.
Has the lady had her medications reviewed?
Has she had her medications reviewed? Yes, a previous psych registrar with our service did have a look at her medications and actually rationalised some medications out.
Has she ever tried to taper her use rather than going cold turkey?
In her previous attempt to cease cannabis use, that was the way it was being done, and due to an increase in stressors, she actually got to a certain point and then stopped.
And one more from me, if I may. She states that she wants to complete a cannabis withdrawal. She's employed. Is the employment working out well, and is she managing to maintain and keep her employment despite her cannabis use?
Yes, she does manage to moderate her use, and her employment is currently going well.
A couple of questions in the chat for you. One of them would be, did she have an exacerbation of her mental health symptoms when she tried reducing cannabis previously?
The major issue when she tried to reduce previously was a significant increase in her anxiety.
So one of the comment is it right that she's receiving no treatment for her mental health and that she's using cannabis to cope? We probably need to bring this up to date, Sharon. So we'll plead guilty that the case that's been presented to you was as it was 3 months ago?
Yes.
Yeah. Because it was a good one to discuss. So perhaps we can bring it up to date in a sec. So what we would normally do in an echo session is, having clarified the case that's been presented, give you, as a community of practice, the opportunity to make suggestions to Sharon as the treating practitioner as to how we might go forward. And then after we've heard your suggestions, we'll perhaps plead guilty to what we've done. Up the back there, go for a run.
I guess I'm coming back to an earlier question. I wonder whether there needs to be a full mental health review of this client, given her presentation, given her history, given the fact that when she withdraws from cannabis, she sees an increase in her anxiety. I feel like there is a full review of this client that's needed.
Got a comment? No? mental health review. Perfectly reasonable suggestion. Any other suggestions as to...
We've got AOD and mental health having the same conversation at the same time with this client, and and I just the only thing it's missing for me is the cultural aspect, because then you'd have AOD, mental health, and cultural support within that. So that's really good, and it's a working document, right?
Yeah, well...
Because it's Aboriginal ways of knowing, doing and being. So when we talk about, we always box, out in Western way of doing it, you box, AOD, mental health, and then cultural support. Where I'm just saying, like, AOD, we're so close to working to the way of Aboriginal ways knowing and being and doing.
Yeah, we're a bit privileged because we've got AOD and mental health in the same place. Which is... and quite clearly we've created the AOD mental health ECHO because we really believe in this, and we actually started this before the Royal Commission. I mean, we're 2 years into this, 18 months.
And there's just so much more. I'm just the conversation, so like a cultural lens from an Australian perspective across the ECHO project. I'd really like to, I guess, sort of see how that develops in that form, that intake form of the case.
Open to criticism.
No, it wasn't no.
We'll have a yarn.
I've got someone online who has, I guess it's partially a question, partially an answer. So the first question was, has there been a holistic health review undertaken? And then in the same breath, I'll also add that they wanted to look at including physical healing, sporting activities, social engagement, culture as a protective factor, having family around. So I think that's kind of a two-part question and answer.
I think I'd translate that as a holistic response, involving activity and other activity, not just medication, but the rest of the package.
That's something that we actually try very hard to do. As a service, we tend to try and work with people as a whole, not just in one area of their life. We have seen this happen with this woman. Our psychiatric registrar has been quite heavily involved in, our previous psych registrar was very heavily involved in this woman's care, provided a lot of help and support. And care and recovery clinicians assisted a lot in helping this woman become... She found the job on her own and she did really well, but she's being well supported to continue in community engagement and employment.
There's a comment in the chat that one of us needs to respond to, is psych registrars are only interested in medication. Maybe I should respond to that. I supervise the registrar and know he is not just interested in, or they are not just interested in medication. If they come to us just interested in medication, they get re-educated. I think that's a danger, that there are some doctors in mental health who don't think beyond their prescription pad, but we do a pretty good job of re-educating them. Ably assisted, mental health nurse on one hand, on one side of me, and know that. So if you look at, since that's been raised, I think I need to answer it. The Goulburn Valley Alcohol and Drug Service is actually a consortium of GVHealth with the Salvation Army and Odyssey. So we in fact offer a whole range of services, including therapeutic day rehabilitation. We have workers who have lived experience. So the package that's offered is not just have some drugs and go away. Very much into trying to look at the whole person. This is the most amazingly resilient lady who has our admiration. want to tell the story about the kidnap of her child? Perhaps you...
Just one more question, Ed. Hi. So I would, with working with this particular client and the fact that she's doing so well with work and she's been given such great feedback from work, use that to help with her sense of self and improving that sense of self and her self-esteem, self-efficacy, all of that, because that's going to help with anxiety, that's going to help with a lot of the other issues that have been coming up for her, as well as wanting to quit the cannabis as well. That's going to help with that, because she's not going to feel that when she gets stressed she needs to have as much, because that's what seems to have been happening in the past.
That is some of the work that we do. There's a lot of positive reinforcement. She comes to us often to tell us what she's been told at work. The fact that she went from working 1 or 2 days a week to almost managerial, was it? And she gets a lot of positive feedback from work. She actually brings that to us. That's reinforced by us, and so the cycle goes. As Ed said, this woman is well admired by pretty much all of the clinicians in our service. She has been through so much, and yet she continues to keep moving forward despite some fairly horrendous things that have happened. Ed did just ask me to briefly touch on what happened. This woman was, I think, 2 or 3 days into her GHB withdrawal when she discovered that her 3-year-old child, had been taken by the child's father. The child was in the care of her mother, the client's mother, and the father picked the child up for an access visit, didn't return the child. It was 2 or 3 days later that Mum informed this woman that the child had been taken. She, fairly understandably to me as a mum, was beside herself and made the decision that she was going to go and get this child back. The child had been taken out of state. Liaising with us the whole time, she followed her former partner from Victoria to New South Wales and then to Queensland, keeping in touch with us and the authorities the whole way, doing most of the liaison herself with family services and law enforcement to get to the child and bring the child back home.
At the time when all of the states were locked down, I must add, she managed to make it to Queensland and back with the child. This is a very resilient lady. So are there any other suggestions as to how we might go forward? I mean, I think we've given you a bit of a hint that she's getting a lot of support from all of us, individually and collectively. So I can perhaps answer a question that was asked earlier. She does in fact have ADHD, which is the cause of many of her previous bizarre diagnoses. She has responded extremely well. She's much more settled and calm. And for my sins, she's now given me her 18-year-old who is even further out on the ADHD spectrum.
I had a similar client, but he's a male. And that time I was thought he probably had an ADHD, and then he had an assessment. And after he diagnosed with ADHD, he took medication for ADHD, and then since then it really helped in reducing his cannabis, and that has been working with him. And it seems like a lot of the problem with the cannabis use is to make him like calm down. and that really helped with the ADHD also.
That's something that we do find. We do, when we do assessments, we're always on the lookout for things that might indicate that someone is self-medicating ADHD. I mean, it's not the only thing that we look for self-medication of, but we're under Ed's tutelage, we're all sort of getting a bit of a handle on the sorts of things we need to be looking for. And we do find that once we start treating the underlying issues, and particularly with ADHD, it can be quite prominent and quite marked, that when you start treating the underlying causes of drug use, the drug use can, in and of itself, decrease and cease. So it's about getting to why people are using.
I'm going to answer a couple of questions that I've got. One, I've been rudely sitting on a question for a long time, and Suzanne asked about training for running ECHO. If you're going to run an ECHO which is recognised by the ECHO Institute and becomes part of the worldwide ECHO system, then yes, training is required. At this stage, I mean, we're lucky enough to go to Albuquerque for training just immediately pre-COVID. There is the possibility of training now with Department of Health in Queensland, and if government would be kind enough to give us a bit more money, we'd run a training hub here in Victoria. And somebody said that Josie said that they're running a similar sort of program, and I'm sure lots of other people have case-based discussions. I think that, I mean, I personally, and I think as a team, we're fairly committed to the ECHO model. It's internationally recognised. It's stood the test of time. But obviously there are lots of other ways of having case-based discussions. This model works. I've also had comments in the chat about Richard's trauma therapy and the need to deal with her trauma. Do you want to talk about that, Sharon?
I'm actually not really in a position to talk a great deal about her trauma. I've not dealt with that part of it a great deal. One of the other clinicians has actually done more work around that.
And certainly from my point of view, I mean, it's not our role to bring up the trauma unless she wants to. I mean, it's something that I know about, but I would not be pursuing it without her wanting that. But yeah.
She's actually shown quite little inclination when I've spoken to her to go into any depth. She acknowledges it, and it's kind of like there's this feeling within her that she will deal with it when she's ready to, and if she feels that she genuinely needs to in order to continue moving forward. She's reasonably content at the moment to acknowledge that these things have happened and to continue to move forward at the moment as she is.
There's a comment in the chat from Kathy that it's very hard to find a specialist who will diagnose ADHD and bulk bill. It's very hard to find a psychiatrist who will bulk bill, isn't it? The management of ADHD in our community could be subject to another discussion which would take some time. I absolutely agree. I think it's horrendous. There are psychiatrists who will treat ADHD in private practice, but I'm not aware of anybody who will treat it in public practice. With the exception, there is a public ADHD clinic in Indigo, which has an 18-month waiting list. It's the only one I know of. If we establish our ADHD and substance use clinic, it will be the only one that I know of. Yes, statistically, 30% of patients presenting for treatment for substance use disorders are likely to have ADHD. They don't all need medication, but they may need some clarification about their position on a neuroatypical scale, and there are lots of other things that can be done other than medication. But recognition of the problem. So many of our patients present with a smorgasbord of alternative diagnoses, many of which are wrong.
I've been quiet. I've only been with GVHealth a little while, since October last year, and I think the ECHO was one of the things that really excited me about what was happening up there in the way that they're jointly managing mental health and AOD issues. The other thing is that, you know, some people find it a little bit daunting to do a presentation at an ECHO because we can have 50, 60 plus people online. The team supports anybody if they've not done that before. If anyone's got an interesting case, the team are very supportive of helping a person actually do a case presentation. So, and I think that's, you know, that sort of notion of that community of practice, as Ed sort of said before, it doesn't matter if you're a Cert 4 AOD worker or you're a professor of addictions. Everyone is actually encouraged to participate, and people do. And if they need support to do that, the team has been incredibly helpful.
And none of us have boring cases, do we? Every single person we see could be presented and discussed, because there's always another aspect. Anyway, Scott, thank you for the opportunity to be here. That's been fun.
Well, thank you, everyone. If I could just make one or two final little comments. I really like the all teach, all learn principle, because I think there's a humility to that I hear that enables Cert 3, Cert 4 people to be involved safely and enjoy the process of being involved, through to extraordinarily well qualified individuals, and everyone's entitled and able to make a contribution, and a valuable contribution, and it's a really nice model. So please join me in thanking Ed, Cheryl and Sharon. It's brilliant. Thank you. Okay, so we'll take a 10-minute break, and then we'll return here in the Celtic Hall for the final closing plenary. Thank you for joining us.